Hello, my name is Cyril Sebastian. I am a neurosurgeon at the Houston Methodist Hospital in the Woodlands. And today I'm going to be speaking about lumbar disc disease. So to start off with, I will go over a little bit about the anatomy of the spine. So a spinal disc is a fibrous structure that acts as a cushion between the spinal vertebrae. There are many discs throughout the spine, but in the lumbar spine, in your lower back, there are usually 5 such discs. Each disc has two main parts, a tough outer ring that's called the annulus fibrosus, and a softer inner part called the nucleus pulposus, which acts as the cushion of the disc. Attaching the disc to the vertebrae are layers of cartilage called the cartilaginous end plates. So as a person ages, the discs in the lumbar spine also age. As they age, they become less hydrated and less flexible. This is a natural process that can be seen on MRIs and CT scans. Sometimes this process can cause pain or symptoms due to nerve compression, and then it becomes a disease, or lumbar degenerative disc disease or lumbar disc disease. There can be many symptoms of lumbar disc disease, and the symptoms can vary in a person from time to time and can vary from person to person. But pain is the most common symptom, commonly low back pain. But symptoms can also occur from compression of nerves in the area of the discs, and this can result in pain, numbness, tingling, and weakness, usually in the legs. A disc can degenerate in various ways. It can degenerate just generally, in which it loses its hydration, becomes less flexible. It can start to bulge and lose its height as well. A portion of the disc, the outer part, can tear, and that can cause a lot of pain. And then a portion of the disc can herniate, meaning the inner part, the soft part, breaks through the outer part and can hit a nerve going down to the leg, causing pain. So I'm going to go over a case that sort of exemplifies one type of lumbar disc disease, and this is a lumbar herniated disc. Now this is a common problem. In this particular patient, who was a 45-year-old female, she developed pain down her left leg. This pain was called sciatica. It went down the back of her leg all the way down to her foot. Sciatica is a type of leg pain that occurs due to compression of nerves in the back. Now, typically when a person has a lumbar disc herniation, the symptoms do get better without any treatment. Typically by 6 weeks, people are feeling a lot better. And so most people don't need any type of treatment, and they'll get better on their own. But if symptoms persist after 6 weeks, you have to start thinking about some type of surgical treatment. Also, if there's progressive weakness or problems with bladder control, it may be time to think about surgery. So in this particular patient, she had no improvement with physical therapy or pain management, and so she elected to proceed with surgery. She underwent a procedure called a lumbar microdiscectomy. In this procedure, the disc herniation is actually cut out under a microscope, hence the term microdiscectomy. This was done by another surgeon. She did well. Her pain improved for about 2 weeks, but then it started to return. She started getting pain down the leg, numbness, and tingling. So she tried physical therapy, but the pain kept getting worse, and that's when she came to see me. So what this shows on the left side is an MRI of the lumbar spine. This is a side view showing vertebrae and the discs in between them. And you can see these discs may be bulging a little bit. Back here you see nerve rootlets running down the spinal canal before they leave to go down to the legs. And then the wider areas are spinal fluid. This disc here is the problematic disc. There's a portion of the disc back here that is herniated all the way around here, and that's pushing the nerves that pass by there and causing your symptoms. On the right side of the screen is another view called an axial view. This is like I'm looking up her spine toward her head. This is the main part of the disc here, and this is the herniation. This area here is the spinal canal. On the left, which is actually the patient's right side, is the whitish area, again, is spinal fluid, and the gray little dots that you see are nerve rootlets. So normally this fills this entire area, but this disc is pushing everything over to the right and causing her symptoms. You can also see a gap in the bone here from her prior surgery. So I took her back to surgery to do a redo microdiscectomy. So this is after we have already started. This is the initial part of the surgery. The patient is already asleep. What we're seeing exposed is her lower back. And this long tube here is called a dilator. I started off with a narrow dilator and progressively increased the size of it until I got to this size. The dilator goes down to the spine. Once I get to the right size, I then put this black tube that slides over it down flush to the skin. This is a retractor tube or tubular retractor, and this allows us access to the spine. And then this is attached to a snake arm or a flexible arm to the bed. And this arm can be loosened or tightened as needed to move the retractor tube as necessary. So once all this is in place, the dilator is removed and the tube goes in between the muscles down to the spine, and that gives us our access to the area we want to see. So this is the next step. So the ring that you see is the retractor tube, and I'm actually looking down the retractor tube toward the spine. This opening here is about 18 millimeters, so it's less than an inch wide. And what you can see here is the initial view before I've really done a whole lot. Here, this arrow here points to the bone edge. A portion of the bone has already been removed in the prior surgery, and this is scarring from the prior surgery. And down here you can see some of the muscle that we're going past to get down to the spine. So in this next view, I've actually removed a part of the bone so you can't really see it anymore. And this is to get around the scar tissue. I don't want to dive right into the scar tissue because the scar tissue distorts the anatomy and there is a risk of injury to some important nerves in that area. So I've removed some of the bone and then gotten around the scar tissue and then removed the scar tissue. And now what you can see is up here, the narrow arrow is pointing to an area called the thecal sac, which contains the nerves that run in the spinal canal. This was the area that we saw on the MRI kind of pushed over to one side. And then the larger arrow points to the actual disc herniation, which has the consistency of crab meat. So at this point, I started removing this disc herniation. Sometimes the herniation will come out all in one piece. Sometimes it comes out in pieces. And in this particular case, it came out in multiple pieces. And I kept removing it until it came out. Now this view is under a microscope. So it's hard to see through here without any magnification. So typically a microscope or some magnifying glasses called loupes are used. So in this view, again, I'm looking down the tube through the microscope, but the disc has been removed. And now what you see, the star points to the area where the disc was. It's gone now. The thecal sac, where the nerves are, is now more visible, and that's because it has moved back into a normal position because it is no longer being compressed by the disc herniation. And then here is something new that we didn't see initially, is the nerve root, which is the larger nerve that comes off of the thecal sac and goes down to the leg. This wasn't visible in the beginning because the disc was pushing it out of the way. And now the nerve root has come back into position where it's supposed to be. So after this is essentially the end of the major part of the procedure. We take the tube out and then close everything up. The patient is allowed to awaken. So after the surgery, she did well. Her symptoms resolved and did not return. Her numbness, pain, weakness all went away, and she had a good recovery. So thank you for listening. I hope you learned something. Again, I'm Cyril Sebastian from the Methodist Hospital in the Woodlands.